Good morning, everybody. I am here to discuss the typical and atypical features of central serous chorioretinopathy. And as we just discussed, it's basically an inner choroidal hypopermeability, which later leads to RP decompensation. And usually, young males with type A personality, unilateral and corticosteroid use is a strong risk factor. And they present with usual blurring of vision or central scotoma, increasing hypermetropia, and the vision usually ranges between 66 to 60. And even after the acute CSCR resolves and the vision returns to normal, usually the contrast sensitivity remains to be subnormal. And coming to the typical picture, a young male with acute localized serous detachment at the macula, and angiography, it shows point leakage, ink blot type of leakage in 93% of the cases. And smokestack type of leakage is seen angiographically, like here, in around 7% of the patients. The natural history, around 60% of the cases of acute typical CSCR resolves within 3 months without intervention spontaneously. Now the slight atypia starts here when you have a subfoveal ink blot and a perifoveal smokestack, which cannot be managed with a conventional focal laser. You have to go to either TTT or PDT, which will be discussed later. So the post-TTT photograph showing complete regression. Again, persistent CSR more than 6 months with subfoveal ink blot leakage. Again, it's an atypical feature. We have to resolve to either one of the, not the conventional method of management. The atypical CSR happens usually in older patients with RP degeneration, pigmentation, and usually they have bilateral involvement. And one atypia is a subfoveal PED like this, seen here, a large subfoveal PED. And this happens within 5 to 60% of the cases of CSCR. And here we have a patient with very large PED with a leaking edge of the PED in a smokestack, a typical smokestack pattern here. So this, if you follow the conventional focal laser to the edge of the PED, sometimes could be disastrous, as in this patient, where it has ripped the RP following the focal laser, and you have a large dense subretinal fibrin under the macula and a large serous detachment with the inferior RD. So typical CSR, now OCT showing a subfoveal PED, and here also the large PED with leakage on fluorescent ICG angiography, and post-treatment the PED goes down and then the fluid resolves. So this is another atypical feature is bilateral multiple PEDs, and in the left eye shows multiple actively leaking PEDs. So this is also an atypical presentation wherein you cannot resort to treat with a focal conventional treatment modality. Another atypical form of CSCR is you see a subretinal grayish white lesion with minimal fluid under the macula, should not be mistaken for a CNVM. Occult type of CNVM. There is no point leakage here on angiography, but there is a late non-specific leak in the area of lesion. So this is a CSCR with subretinal fibrin and multiple PEDs. So that's a clue for CSCR. And ICG angiography in these cases show hyperpermeability in the midface, and OCT shows subfoveal PED, subfoveal fibrin, and serous detachment at the macula. So one of the treatment modalities, TTT or PDT, the fluid goes away, only the multiple PEDs remain, and the only dry macula with PEDs. Another leakage with a non-specific type of atypical leakage you see on angiography, and OCT shows some PED, subretinal dot echoes. This is actually the fibrin which looks on the OCT, and post-treatment showing resolution of fluid, fibrin, everything. Again, a typical CSR with a bridging tissue. So these are PEDs, and you have bridging tissues connecting to the PED, and sometimes this bridging attachment should be the point of leakage on angiography, and micro rip like this can be the source of leakage in fluorescein angiography. Again, a typical leakage with bridging tissue connecting to the PED. Post TTT showing the tissue getting released, and it becomes a typical CSR with smokestack pattern after 3 months, showing a complete resolution post treatment. So another atypical form is an inferior bullous RD with fibrin under the macula. So this also cannot be treated with a conventional treatment. Either TTT or PDT has to be resolved and resorted to. And the chronic CSR usually more than 6 months duration, and around 16% of such patients progress from acute to chronic phase, where you have RP degeneration. And this constitutes around 5 to 10% of CSCR cases, this chronic CSR. Older patients, decreased vision, RP atrophy, and shallow SRF usually. So vision prognosis also guarded. Here you have a patient with chronic CSR and fibrin with a late non-specific leakage without focal leakage. So one of the modalities will TTT or PDT might resolve in complete resolution. Again, OCT feature of a thick fibrin which mimics like a CNVM, and post-treatment only the PED remains and the rest of it resolves. So another is a diffuse ooze or diffuse epitheliopathy in chronic shallow CSR. Like here the angiography and ICG shows hyperpermeability leakage post treatment. Again with foveal thinning the CSR resolves. Another feature is angiography and ICG angiography correlation. Sometimes you see angiographic ICG angiography show hyperpermeability in not corresponding to the area of fluorescein angiography. So post PDT or TTT, the hyperpermeability resolves in the area of treatment. Here you see a hypopermeability in that area. Again, even in an almost resolved CSCR with a small PED, you see a lot of leakage on ICG angiography, and even in the other eye, uninvolved eye, you see hyperpermeability in ICG angiography. With chronic CSR and no obvious leak, again on angiography, you see multiple areas of hyperpermeability in this ICG. So the question is whether to base your treatment on based on the ICG angiography or fluorescein, which we resort mostly to fluorescein based treatment. So recurrent CSR happens in 15 to 50% of the cases of CSR, less bullous, poorer vision prognosis, and reduced final vision compared to the acute CSR. So the predictors of poor visual acuity, the most common picture is like this. You have multiple cystoid changes and RP degeneration. Sometimes the OCT picture may be confused for a CNVM also, but this is actually cystoid macular degeneration, which is a late complication of CSR, chronic CSR. So this is a poor prognostic factor. Other poor prognostic factors are presence of secondary CNVM, persistent PEDs and SRF, duration more than 5 years. Some studies showed more than 3 years, and subretinal gliosis or fibrosis. So secondary CNVM happens in 0.3 to 2% of chronic CSR cases. And coming to lesions looking like this, so the similar picture you would see like a typical CSR and a serous PED like this should not be confused for a PED like this. Here the clue is a notched PED, irregular PED, and sometimes you see under the pigment epithelium you see dot echoes on the OCT, and the discontinuity of the Brooks membrane layer, which also suggestive of fibrovascular PED or sometimes in polyps. So occult CNV has a different type of leakage. It's a stippled hyperfluorescence with late non-specific leak suggestive of occult CNVM. ICG might show a hot spot like this, which is not a usual feature of a chronic CSR, which shows a diffuse in the mid-phase hyperpermeability. And ONH pit can have in 45% of the cases CSR type of macular detachment. and but this usually starts with a skytic changes in the OCT like this, and on angiography you will not see any point leakage like a CSCR. So this entity should be kept in mind and should look for a pit like this, small pit on the edge of the ONH. Another differentiating condition we should not get confused is a polypoidal choroidal vasculopathy can sometimes present with serous PED, sometimes serosanguinous where the picture is diagnosis is clear cut, but with in this case the angiography will show multiple nodular focal areas of nodular hyperfluorescence, and you many a case will see branching vascular network on ICG angiography, where this should be done to differentiate the condition. Another condition is with serous macular detachment on OCT with a elevator like this could be a choroidal hemangioma, but here we could see a orangish mass at the posterior pole. Also the angiographic pattern of hyperfluorescent fine lacy network called multi-lake appearance within the intrinsic vessels of the angioma, and late leakage is characteristic of choroidal hemangioma with serous detachment. Another case is APM PPE, which is a uveitic entity with multiple posterior gray-white lesions, and here the angiography will show like this early hypofluorescence and late hyperfluorescence, unlike in CSCR and ICG angiography is also hypofluorescence in early and both in early and late phases. And Harada's disease is another uveitic entity which can present with multiple serous detachment of the macula. And here the punctate hyperfluorescence like this in bilateral with late pooling of the dye is the starry sky appearance is classical of the Harada's disease. Another with serous detachment, retinal detachment which could mimic a teardrop CSR is uveal effusion syndrome, wherein diagnosed scleral thickening greater than 2 millimeter is characteristic of uveal effusion syndrome, not of CSCR. But we have had very few patients with chronic CSCR with similar appearing picture. Another differentiating is serous macular detachment associated with choroidal folds and ONH edema, optic nerve head edema. Should keep in mind posterior scleritis, where you should see choroidal thickening with subtenon effusion in should be differentiated from chronic atypical CSCR. And malignant hypertension also can have serous macular detachment, but obviously the other features are very clear cut. And another picture is if you have a grayish white subretinal lesion like this and a serous detachment, macular detachment like this, then the inflammatory causes should be ruled out, because sometimes the subretinal fibrin can be, people can mistake for a chorioretinitis with a serous macular detachment. So if you give steroids for this, actually you will be worsening the chronic CSR with fibrin. Again, the angiography with early late hypofluorescence with late hyperfluorescence will be characteristic of chorioretinitis. So to conclude, central serous retinopathy will have a varied clinical presentation and is still an enigma with respect to its exact etiology. It is very important for the ophthalmologist to understand the spectrum of the disease and the disease mimicking CSCR so that appropriate treatment can be instituted to the patient. Thank you for patient listening.